Good afternoon, everyone. Last class, I had discussed about temporomandibular joint ankylosis. I think we had stopped in the management process. Yes. Yes. Uh, I'll brush up once again regarding the Kaban's protocol. Okay, I had explained this in the last class, but today I will be again brushing it up, revising it again. See, Kaban's protocol is management of temporomandibular joint ankylosis in children. Okay. So in children, Kaban had come up with a protocol in 1990 that is first thing in the management of temporomandibular joint ankylosis is aggressive resection. Okay, that is resection of 1 to 1.5 centimeters, also called as gap arthroplasty. Aggressive resection, that is aggressive removal of the tumor mass. Then ipsilateral coronoidectomy, that means removal of the coronoid process on the involved side. The condyle anyhow we are removing in aggressive resection. Condyle has been removed in aggressive resection. Now coronoid is also removed on the same side. So once if the mouth opening is more than 35 mm, then we will not go ahead with the opposite side. If the mouth opening is less than 35 mm, even after performing the aggressive resection and ipsilateral coronoidectomy, if mouth opening is less than 35, then what we do is we go ahead with the opposite side removal of coronoids. That is contralateral coronoidectomy. So this is the third step of Kaban's protocol. Then fourth step is lining of temporomandibular joint with temporalis fascia or cartilage. So this is also called as interpositional gap arthroplasty. That is placement of interpositional materials in between so that re-ankylosis is prevented. Then reconstruction of ramus using costochondral grafts. Reconstruction of ramus. The ramus is reconstructed using costochondral grafts. Then rigid fixation and early immobilization with aggressive physiotherapy. So these are the 7 steps of Kaban's protocol in management of temporomandibular joint ankylosis in children. Okay. First is aggressive resection, ipsilateral coronoidectomy. If mouth opening is less than 35 mm, then contralateral coronoidectomy. Then after this, we place a material in between the TMJ, that is in between the coronoid process, like in between the ramus and the glenoid fossa. Then reconstruction of ramus. Now there is no ramus. The ramus is reconstructed because the condyle is reconstructed. That is with the help of a costochondral graft. Okay, we make a pseudocondyle graft. So this will be rigidly fixed with the ramus of mandible. That is why rigid fixation, plates and screws. Then early immobilization and aggressive physiotherapy. Physiotherapy is exercises of the joints so that to prevent the re-ankylosis. So we are placing interpositional material, that is temporalis fascia, cartilage or some other material, so that re-ankylosis is prevented, and early immobilization, aggressive physiotherapy, so that re-ankylosis is prevented. Now coming to the other treatment options of temporomandibular joint ankylosis. Now, in children, we are grafting it with costochondral grafts. Why? Because still growth has not been achieved in children. So, if we use cartilage as a replacement of condyles, then we can achieve some kind of growth in that region. So, now the treatment options in adults. The treatment option in adults is either gap arthroplasty, interpositional gap arthroplasty. Gap arthroplasty is same thing, that is removal of the mass, ankylotic mass. Interpositional gap arthroplasty means removal of the mass and placing a barrier in between so that re-ankylosis is prevented. Now, the different materials which are used in interpositional arthroplasty, they are autogenous, heterogeneous, and alloplastic. So, autogenous materials are temporalis muscle, temporalis fascia, fascia lata, cartilaginous grafts, those are osteochondral, metatarsal, staphyclavicular, auricular grafts, dermis fat can also be placed. So, these are the autogenous grafts which can be used as interpositional arthroplasty. Heterogeneous are chromatized submucosa of flex bladder, lyophilized bovine cartilage, half elements. Alloplastic could be a metallic and non-metallic. Non-metallic are mostly silicon, elastic, teflon, acrylic, nylon, ceramic. Uh, Metallic are titanium, stainless steel, or gold. So these are artificial condyles which are made with metallic or non-metallic uh, materials. So which are also acts as a barriers. So I'll show you now the barriers there. See, this is the ankylotic mass. So what is the first step? The first step is graph arthroplasty. It is removal of this ankylotic mass. So when this ankylotic mass is removed, it is called as gap arthroplasty. So in case of children, what we are doing, we are placing a cartilage here, which acts as a condyle. So condyle, cartilaginous condyle will also help in stimulation of growth. In case of children only we do, because growth is still not achieved in children. So there it is recommended to use osteochondral grafts. Whereas in adults, already the growth has been achieved. So growth is not a problem, only function is a problem. So this ankylotic mass has to be removed. So once this is removed, so the condyle, so there is a gap here. So this is what called as gap arthroplasty. Now in this gap, if you place some barrier, so that's called as interpositional gap arthroplasty. Why we are placing barrier? We are placing barrier because we have to prevent the ankylosis, re-ankylosis. So barrier will prevent the re-ankylosis. It will also act as a disc-like artificial disc. So now we know the materials also which can be used. So those could be autogenous, heterogeneous, or alloplastic. Now coming to the objectives of management of temporomandibular joint ankylosis, the surgical objectives. One is we need a maximize exposure. Okay, that is exposure should be maximum to the temporomandibular joint region. Second is preservation of facial nerve, major vessels, and parotid gland. So these are the major structures which are present in the region of temporomandibular joint. That is, facial nerve is present, then parotid gland is present. So we have to preserve this facial nerves, parotid glands, and branches of external carotid artery. Now, preservation of these things, maximum exposure of the joint region, and maximum uses of skin creases. Skin creases means, see, there are some folds, natural folds in the skin. See this. So if we use the incision in those skin creases, then the chances of scar formation is minimum. So that is why it is recommended that incisions has to be taken in the skin creases only, if wherever possible. So these are the objectives: maximum exposure, preservation of the vital structures, nerve, vessels, and parotid gland, and maximum use of skin creases. Now, how to gain surgical access to the temporomandibular joint? So, surgical access to the temporomandibular joint is gained by few approaches. So, what are those approaches? Those are pre-auricular approach, that is in front of the ear, and oral is through the ear, post-auricular is behind the ear, rhytidectomy is involving the ear and the neck region, submandibular, below the lower part of the mandible, and intraoral. So these are the approaches through which we can reach the condylar region. So these are the approaches which are used in treatment used in gaining the access to the temporomandibular joint for removal of the ankylotic mass. It is very simple. Preauricular, endoaural, postauricular, rightidectomy, submandibular, and intraaural. Okay. Pre, intraaural, preauricular, intraaural, sorry, preauricular, endoaural, postauricular, rightidectomy, which is behind the mandible. Below the mandible, which is submandibular and intraaural approach. So coming to the premolecular approach, it is also called as Blair's approach. Okay, so this is the premolecular. The incision is taken in the preauricular region. So once it is involving removal of the part of the ear skin, then it becomes endoral. Then if the incision is taken from behind, it becomes postauricular. Now here we find the coronoid process behind the skin and the muscles. So in this region, auricular region, we have the condyle. So we have to reach this region because there is a fusion of condyle with the glenoid fossa in this region only. Okay. Hence, this approach is very easier and it provides good exposure to the directly to the condyle. Whereas postauricular also used, but it is a complicated approach. Now, as I told you, there are two options. One is gap arthroplasty, second is interpositional gap arthroplasty. Gap arthroplasty just means removal of the ankylotic mass and creating a gap in the temporomandibular joint region. Interpositional arthroplasty, we are placing an interpositional material. We are placing a barrier. Okay, glenoid fossa and the ramus. We are placing a barrier. So now, when we are placing a barrier, we generally use autogenous. So autogenous means the what we can use the nearby region we can use the fascia and the muscle, which is that temporalis, this region, temporalis region. So I'll come to that. I'll explain it. Yes. Yeah, this from this region here. So we reflect we take a finger shape growth of temporalis muscle and the fascia from this region, and we roll it into the resected region. I have a picture for it. I'll show you. Yeah, this is it. Temporalis region. A finger width flap is elevated. This finger width flap elevated. Now this finger width flap is elevated. After this is done after gap arthroplasty. Now once gap arthroplasty is done, removal of the ankylotic mass. So this will be rotated in the gap arthroplasty region and then suture it off. So now this approach is a modification of preauricular approach. Okay. So this is preauricular approach till here. From here there is a question mark type. Okay. Like this. Okay. So this approach exposes the temporalis muscle. So this approach is also called as modified preauricular approach or Alcar-Bremlis approach. So in this approach, what we can do is we can remove the gap, we can remove the ankylotic mass. That is, we can perform the gap arthroplasty as well as we can also do the interpositional gap arthroplasty. We can take the interpositional material, that is a finger width flap from here, and then rotate it and place it and stitch it in the region of gap arthroplasty. So this approach is called as Alcar-Bremlis approach. So it's a modification of preauricular approach. In preauricular approach, what happens? We will just gain access to the condyle region. So once we gain access to the condyle region, we can remove the ankylotic mass. So incision is taken in the skin initially, then subcutaneous fat, then we dissect the fat, preserving the vessels. We reach the condylar region, remove the ankylotic mass, and then suture it. If you suture it back, then it becomes gap arthroplasty. Or if we take a modification of this approach, that is or temporal modification, then what we can do is we can reflect a flap from the temporalis fascia flap from there, and we can put the temporalis fascia muscle in the resected region as a interpositional material. Then suture it off. That is Alcat Bramley's approach. Similarly, post-auricular approach, incision is taken behind the ear. This is a complicated one because whole of the ear has to be taken retracted anteriorly. So retracting whole of the ear anteriorly is a bit difficult and complicated approach. This is very rarely done. Okay. Then submandibular approach is in the submandibular region. Then from here the flap is reflected. So from this flap, gaining access to the temporomandibular joint region is difficult. So generally, this approach is used in combination. I'll explain you how what combination. See, what we do is through a preauricular approach or a Alcat-Brimley approach, we resect the ankylotic mask from here. Then, if required, we do a interpositional arthroplasty also. Right? Now, especially in case of children, what we do is we do gap arthroplasty, and we have to create an artificial condyle here by postcoronal grafting through rigid fixation. That time, what we require is we require a fixation, plate fixation here in this region. So if we require a plate fixation in this region, then through here fixing a plate would be difficult. In that time, what we can do is we can take a submandibular approach, and it helps in fixing the screws here, pegs and screws here. So generally, in combination, we use this approach. Or else removing the condyle process from this approach is very difficult. It is generally used in combination. And similarly, intraoral approach is also very difficult. Through intraoral, reaching the condyle is very difficult. Coronary process removal can be done through intraoral approaches. So let us revise once again the surgical approaches. They are preauricular. Modification of preauricular is Alcat Bremlis approach, that is a question mark like inverted question mark like extension in the temporalis region, from where we can elevate a temporal muscle flap or a temporal facial flap, which can be inserted as an interpositional material in the resected region. Endoral is through the ear. That is, endoral are more aesthetic than the preauricular, because in preauricular there will be a visible scar. In endoral, the scar will be inside the ear. Then post-auricular one is a difficult one because whole of the ear has to be reflected anteriorly. It's a complicated approach. Then rhytidectomy approach is a combination of extension of preauricular in the retromandibular region. So this is also a good approach, but the problem is damage to the facial nerve and the parietal gland is more in cases of rhytidectomy approaches. But the access is very, very good in rhytidectomy approaches because preauricular and the lower border of the mandible is also exposed in rhytidectomy approach. Then submandibular approach and intraoral approaches, as I told you, it is very difficult to reach the coronary process. So these are the approaches that can be commonly used in combinations with the other approaches. So the surgical management, as I told you, is coronarectomy, gap arthroplasty, and positional gap arthroplasty. So this is regarding the gap arthroplasty. Okay, removing the ankylotic mass. The gap has to be a minimum of 1 to 1.75 centimeters so that re-ankylosis has to be prevented, and care has to be taken not to damage the roof of glenoid fossa because we will enter into the middle cranial fossa, okay, which is very dangerous. Interpositional, same thing I told you. Once this gap arthroplasty is done and remove the ankylotic mass is removed, then we prevent the re-ankylosis. we are placing a material. Then coming to the complications of surgeries. The complication of the temporomandibular joint surgeries are intraoperative, postoperative. Intraoperative could be hemorrhage, okay, damage to any superficial temporal vessels, facial artery, okay, damage to the external auditory meatus, damage to the zygomatic and temporal meninges of the facial nerve, damage to the auriculotemporal nerve, damage to the parotid gland, damage to the. So these are the intraoperative. That is why damage to teeth is we want now initially there is a no mouth opening. We want to increase the mouth opening. We put pressure, the forcible mouth openings on the teeth, and we try to increase the mouth opening. Then we can cause damage to the teeth region, and as well as during intubation, also we can do damage to the teeth. Then others are the structures which are present in that region: parotid gland, auriculotemporal nerves, zygomatic cluster, facial nerves, external auditory meatus, then transverse facial arteries, facial temporal vessels. So all these things, damage to vessels, nerve, artery, ear, parotid gland. Remember this: nerve, vessel, artery, parotid gland. Nerves are auriculotemporal and the branches of facial nerve, that is temporal and zygomatic branch. Then superficial temporal vessels, association artery, and anesthetic. These are the intraoperative complications. Postoperative complications will be infection in that region and open bite. Open bite because you have made a gap arthroplasty, so generally there are chances of premature contact in the posterior region. Once there is premature contact in the posterior region, there will be an anterior open bite. So these are the complications of surgery. Postoperative care is monitoring of airway and bleeding after surgery. Early joint mobilization, that is, movement of the joints has to be taken place. Physiotherapy has to be continued. Uh, it has to be aggressive, that is, patient should be asked to regularly do exercises. Ice packs can be given, followed by hot packs for relaxation of muscles. Finger exercises can be done, and as well as tongue depressors or wedges. The wedges, the wooden wedges can be placed to slowly guide in increase in mouth opening. So physiotherapy is important. Early mobilization and physiotherapy is important in the postoperative time. The recurrence of the temporomandibular joint ankylosis, inadequate gap created between the fragments. If the gap is inadequate, then there will be a recurrence. As I've told you, in gap arthroplasty, there has to be a minimum of 1 centimeter or 1.5 centimeter of gap in between the two fragments, the lunar fossa and the lummus of lambda. And then the postoperative graft fractures, or if it is not fixed rigidly to the ramus of mandible, then what happens? There won't be a fusion there. It can cause a hindrance in movements and ankylosis, inadequate coverage of the glenoid fossa, inadequate postoperative physiotherapy, high osteogenic potential and periosteal osteogenic power may be responsible for high rate of reankylosis, that is recurrence in case of children. Yeah, this completes the temporomandibular joint ankylosis. So, in temporomandibular joint ankylosis, I think I've covered everything that is from the definition. What is ankylosis? True and pseudo ankylosis, the classification. I'll just dish it in short. Papazian's classification, Sauner's classifications, the etiology, the pathogenesis, or the pathogenesis of ankylosis is then clinical manifestations, then the clinical features of ankylosis, that is unilateral ankylosis and bilateral ankylosis, then radiological feature, the main thing, antigonial notch is appreciated on the radiographs, specialized scans like 3D CT scans and all. Then the reasons why ankylosis is more in cases of children. Then is surgical treatment options. These are covered today. There is Kaban's protocol in management. See the basic difference between the Kaban's protocol and the treatment management of adult ankylosis is only thing is Reconstruction of ramus using osteochondral graft is considered in case of children because the growth is still not complete. Okay. To achieve growth, we do this step extra. Reconstruction of ramus with osteochondral graft and rigid fixation, whereas this is not considered in case of adults. Whereas in adults, if the case is very severe, then we can do a complete joint replacement. Whereas replacement of the joint by titanium, stainless steel, or acrylic structures, silicone structures. That is also called as total joint replacement. Then these are the various interpositional materials: heterogeneous, heterogeneous, holoplastic. Then the objectives, then the surgical exposures, approaches, preauricular, embolicular, postauricular, hysterectomy, submandibular, intraoral approach, postauricular. This is the most common approach, that is Alcott-Bentley approach, which is commonly used in practice for ankylosis treatment. Because we can do a gap arthroplasty as well as interpositional arthroplasty with this approach, with a similar same approach. No need of two surgeries. Okay. Complications of this are as damage to the arteries, vessels, nerves, cardiac gland. Post-operative care, only thing is joint immobilization is done as soon as possible and aggressive physiotherapy has to be done. Then the causes of re-ankylosis, that's it. I think we have time, so I'll want to begin the next topic, that is impacted tooth. Only 2 minutes are remaining, okay, so I'll continue better, I'll continue in the next class itself. So I'll be continuing the impacted tooth lecture in next class. It's better. Once again, I will explain you the ankylosis. Okay, it is fusion of the bony surfaces of joint, true and false ankylosis. True are intra-articular, false are extra-articular. Okay, intra-articular is a complete, incomplete. Extra-articular, it could be a bony fibrous. Okay, Topazi are classified them as type 1, type 2, and type 3. Type 1 affects the condyles only. Type 2 is intermediate between condyle and coronoid. Type 3 is involving all the condyle, coronoid, and the cranium. Rowe classified them according to the tissue involved. That is fibrous ankylosis, fibrous ankylosis, osseous ankylosis, cartilaginous ankylosis, osteocartilaginous ankylosis. That is based on the type of tissue. In some may classify them as type 1, type 2, type 3, type 4. Type 1 is condyle is still present, okay, but it is deformed. Condyle is type 2, condyle is present, but there is a fusion in the anterior and posterior surfaces. In type 3, there is a bony block, that is, whole of the condyle is obliterated, but the condylar head can be appreciated a bit. Here, everything is gone in type 4. Etiology, trauma during forceps deliveries, In case of that was in case of olden days where forceps delivery is practiced. Nowadays, the forceps delivery trauma is almost nil. Then certain microorganisms which can reach the joint through lacerated wound or bloodstream through septicemia and all, or direct extension from the infection into the neighboring region. So these are the microorganisms which is commonly seen. Staphylococcus, streptococci, and occasionally gunner. Pathogenesis, see, trauma, microtrauma, infections, all these can lead to hemolysis, can lead to drop in O2 tension and pH. So this drop in O2 tension and pH will promote osteosynthesis. So this osteosynthesis leads to helpful formation of alkalotic mass. Clinical manifestations can vary vary according to the severity, time of onset, duration of it. In early, see that's what I told. Early and late. In early, that means 12 to 15 years or before that, there is severe facial deformity and loss of functions. Late, that is after 15 years, there is only facial deformity. Function, facial deformity is there, function loss is there. That is, growth is completed. So only functional loss is there. Facial deformity will be nil after 15 years. If it is within 15 years, that is early age to 12 to 15 years, there will be facial deformity. More early the onset, more the facial deformity. With the loss of function. Loss of function means plastic history efficiency is lost. See, this is the unilateral ankylosis. Bilateral ankylosis, the face is bilaterally similar, okay, symmetrical, exposed sclera, severe malocclusions, chin throat angle is nil, bird face appearance. Whereas in unilateral, see, actually this is ankylosed. So this is elongated, that means growth has occurred here. But it gives a false impression that this is affected. No, this is affected. We see a roundness on the affected side, elongation or flatness on the unaffected side. So this side pushes towards this side because it is growing, this is non-growing. So this growing side push here. That means deviation to the affected side. So here what happens? The occlusion will be in cross bite, class 2, that is retrographic mandible. Whereas here there would be a open bite. Here cross bites. Got it? So this is a unilateral ankylosis, bilateral ankylosis. Asymmetrical face, symmetrical face, bird faces, exposed sclera, hypoplastic mandible, no chin throat angle, open bite, malocclusion. Here, cross bites because this is flat, normal growing side. So this will push it towards this side. So this side is affected, non-growing side. So the chin gets deviated towards the affected side. Okay, the affected side chin gets deviated. Open bite, the cross bite is seen here. So this is called roundness of face. This is called flatness of face. Radiology, OPG is the gold standard. And I've told you that in OPG what we find is antigonial notches are seen here, okay, on the affected side, and the ankylosing mass will be seen in the condylar region. That is obliteration of the TMJ joint region. Specialized scans are the CT scans, 3D scans, MRI scans. Now, why ankylosis is more in children is because children have articulating surfaces which are highly vascular, flat and broad glenoid fossa. The glenoid fossa is flat and broad, vascular articulating disc, whereas articulating disc is non-vascular in adults. The condyle is thick and stout. That means when there is a trauma, the condyle will burst. It will not fracture. Whereas in adults, the condyle will fracture. Whereas in children, it will burst. Once it bursts, there are multiple fragments, bony fragments spread in that region. So these individual fragments will have a high osteogenic potential. So each fragment will start forming bone. So all these fragments starts forming depositing bone, and what happens normally? There will be a huge deposition of the bone in that region. That is what is called as ankylosing mass. That leads to the fusion of joint with the glenoid fossa. Hemolysis and CO2 tension is more, osteoblastic activity is more in children. So these are the reasons that ankylosis is more in children. Now, what are the two main problems? One is aesthetic problem, that is growth. Second is function. Growth is hampered and functions. So goals will be only two, that is to restore growth and to restore the function. Function is mastication. Growth, that is growth of mandible and the maxilla. So growth and mandibular function improvement are the goals in children. Whereas in adults, growth is complete. So only goal will in the adults should be a improvement of functions. The one's protocol, surgical access. These are the approaches which I discussed today. So the one which we follow is Alcair Bramley's approach. Alcair Bramley. It is a modified preauricular approach. Why this is done? Because in single cell approach we can do gap arthroplasty as well as interpositional. We can position the material inside here in the resected surface. Temporalis muscle can be elevated or muscle with fascia can be taken. Gap arthroplasty, interpositional. Remember this in the management. The one's protocol, adults, gap arthroplasty and interpositional gap arthroplasty. Gap arthroplasty is removal of the coronates. The condyles, coronates can be removed. That is, if mouth opening increases more than 35 mm, then coronate can be left. If it is less than 35, coronate can be removed on the opposite side also. If more than 35 after removing one coronate, then coronates and condylectomy has to be done. Complications, vessels, nerve, gland. Vessels are superficial temporal vessels, facial artery, the ear and parotid glands are the important, and nerve branches of facial nerve, that is zygomatic and temporal branch, auriculotemporal nerve. Post-operative complications are infections and open. Post-operative care, only thing is physiotherapy. Exercise, exercise, exercise. Vigorous exercises can be done to prevent ankylosis. Finger exercises or wedges of ice, tongue depressors, wooden tongue depressors, or the ice cream sticks can be. And slowly, gradually, they have to be increased to improve the water. Recurrence, that's all.